Ladies and gentlemen, dear colleagues, dear friends, good evening. Clinical patient profile and mechanism of action of anti-seizure medicine is the topic for now. These are my disclosures, and I will talk about the landscape of epilepsy overall, and then a little bit about the concept of mechanism of action, which is quite attractive, but there are some implications, and I will use some cases for these implications before I come to conclusions. So first of all, seizures are associated with a very high burden of neurological disorders. What you see here is an increasing number of the global disability-adjusted life years, which are accounted due to cerebrovascular diseases and Alzheimer's disease, here on the right side of the graph in the violet and pinkish color. Epilepsy itself in this global burden of disease study in green seems to be quite a small proportion, but what you should not forget is that up to 25% of patients after stroke have a first seizure within the first year after stroke, 25%, and at least 5% of patients with Alzheimer's disease have seizures. So the right side is the future. The left side of the graph is what we have to learn about the epilepsies themselves, and there seem to be mechanisms which can be shared. What is important that seizure-free patients can lead a normal life almost without measurable disease burden. And that's important. We have to go for seizure freedom. So I talk always about the two loose ends in epilepsy. One is the high number of genetic disorders in younger people. There's an individual challenge, important work groups like rare disease groups work on that topic to detangle that. And the other one are the increasing number of people with stroke and neurodegenerative diseases. They have a high prevalence of seizures in these population group, and they are a big public health challenge. One can learn from the other, and I think therefore we would have better treatments. But one thing I want to say about the mechanism of anti-epileptic drug, they are quite irrelevant to the patient. The brain doesn't want to know the mechanism. We want to have seizure-free patients. So everything what we know about mechanisms of action is a theoretical construct. And this is Leibniz, a German philosopher, and he said that perception and what depends on it cannot be explained mechanically. Any variety of mechanisms need to be relativized to a level of description and explanation. So anti-epileptic drugs work in at least 2/3 of the patients, and this is what we know. Thus, they must have one or more mechanisms by which they exert their effects. That's logic. So the knowledge for the doctor or for the patient of anti-epileptic drug is irrelevant to its effects, and it's irrelevant in clinical practice to know. Some instances, it's good to know what happens, but we have to accept that this is a theoretical construction. So when we look at this slide from, which was presented by Steve White, one of the masters of pharmacology and mechanism of action, well, he presents it as putative major sites of action, and it's mainly GABAergic drugs, what you have to know. It's mainly sodium channel blockers or sodium channel modifiers. And there are a few other drugs which are important to know. It's the SV2A drug, levetiracetam or brivaracetam or celetracetam. And then it's the glutamatergic drug, which act on the AMPA receptor, such as terampanel, or a little bit also topiramate and felbamate, but to a much lesser extent. And there are very few acting on the NMDA receptor. And of course, there are others acting on sodium channels postsynaptically or alpha delta 2 subunits of voltage-gated calcium channel, such as gabapentin and pregabalin. So it's very likely that the drugs have more than one action. And this is what you see here. The main mechanism of action are here depicted in gray. On the left, you see the abbreviation of the drugs. And what you see is that most of the time you have at least 2 or even 3 gray fields because they exert several types of action. One example is probably pregabalin, which seems to have a very clear AMPA-mediated activity. But you have to know that not a single mechanism is responsible for all the clinical effects. The relevant mechanism for any anti-epileptic drug or anti-seizure medicine are likely to be multiple. So where have we progressed? We have a multitude of anti-epileptic drugs or anti-seizure medicine. We may call it first generation anti-seizure medicine and second generation anti-seizure medicine, which are introduced after 1989, and that was vigabatrin, which entered the market after a long, long time. The first generation anti-epileptic drug, in effectiveness, they are very good. There's no drug better than phenobarbital in terms of effectiveness or efficacy. But they have a suboptimal pharmacokinetic. There need to be dose adjustment in the enzyme-inducing drugs, or like phenytoin, they have a nonlinear pharmacokinetic. They have many interaction potential for drug-drug interactions, and they have a propensity to induce adverse effect. Ineffective in about 1/3 of people. The second generation drug are less likely to cause pharmacokinetic interactions. Some of them are pharmacokinetically very good, and they have some advantages in tolerability and safety, for example, in the older patients and maybe also in women, because they have fewer adverse effects and fewer enzyme inducing. And in many of those, we have a better knowledge of the mechanism of action because this is incentivized by the licensing authorities. And the efficacy is the same as in 1900. About 1/3 of patients with epilepsy fail to achieve seizure freedom. Current available drugs are effective in preventing, suppressing seizures, but have no influence on the underlying disease. This is why we should call them anti-seizure medications, as recently published by Jacqueline French and other workers. So 2 patients, one is a 23-year-old woman. Seizure started at the 16th year of life with a feeling of fear, followed by loss of awareness, lip smacking, repeated chewing, purposeless movements, especially involving right hand and arm, and then tonic-clonic seizures, or the seizure stops at that time. The family history: maternal grandmother had episodes of a strange behavior, nothing more is known. The physical and neurological examinations are normal. Interictal EEG shows right temporal intermittent theta delta slowing and occasional right temporal spikes. The MRI was negative, but the diagnosis of temporal lobe epilepsy was made. And the other woman, 26, seizure started in the 21st year of life with sensations beginning with white stripes, followed by palpitations and losing awareness, head version to the left, head twitches and tonic movements of the upper limb. Her mother had 2 generalized tonic-clonic seizures. Examination was normal. And there was a loop recorder implanted because they thought there was syncope, but it was normal. Interictal EEG normal, MRI normal, and the diagnosis of focal, visual to bilateral tonic-clonic seizures of unknown etiology. So this was the anti-seizure medicine in one patient. Carbamazepine, standard of care, plus levetiracetam, plus sonizumab, with no improvement. She was referred for pre-surgical evaluation. Genetic testing reveals an SCN1A pathogenic variant, and surgery was cancelled because they feared a potentially poor outcome. And in view that carbamazepine can aggravate seizures in patients with SCN1A, they discontinued carbamazepine and left her on a sonizumab levetiracetam combination. Seizures remitted and no seizures for the subsequent 16 months. The other patient had lamotrigine and up to 400 milligram and levetiracetam. And when there was acute exacerbation, they sent her to the epilepsy monitoring unit. They had 36 episodes. All of them were psychogenic, non-epileptic seizures. And the mother had seizures due to alcohol medication withdrawal when the patient was 11 years old. Psychosomatic outpatient clinic for epilepsy, psychotherapy was started. So irrespective which mechanism, these patients were not drug resistant. On the left side, it's of course important to know that sodium channel blockers aggravate these patients. And on the right side, you have to have a correct diagnosis. So we are talking about pseudo-drug resistance. Wrong epilepsy diagnosis, for example, when you have idiopathic generalized epilepsies versus focal, because seizure aggravation might occur not only in SCN1A mutations, but also in the idiopathic generalized epilepsy group, especially in JME. Poor adherence, non-compliance, reflex seizures, and psychogenic seizures are one of the common causes of pseudo-drug resistance. Drug resistance, sensu stricto, is only when there is a failure of two adequate trials of two tolerated, appropriately chosen and used anti-seizure medicines, whether as monotherapy or in combination, and they fail to sustain, to achieve sustained seizure freedom. It's not a constant process, it's a dynamic process. It may reflect the dynamics of the underlying pathophysiological process, the epileptic state at one time point. So coming back to the pseudo-resistance, we saw a patient where the knowledge of the mechanism of epilepsy is important to know, SCN1A and sodium channel blocker. Let's go to this example, carbamazepine and phenytoin, sometimes also lamotrigine aggravates JME. So do we have broad spectrum anti-seizure medicines, which would be good, of course, because then you should not be so sure about the seizure type. They are efficacious and effective in all seizure types. So valproic acid, for sure, is working against all seizure types. It's probably a little bit weaker against focal seizures. Perampanel is the drug I'm going to talk about now because there are new data. And lamotrigine, I have a question mark because I feel it's not a broad spectrum, it's a small spectrum. But I come back to that later. Broad spectrum anti-seizure medicines are effective against focal and generalized seizures of any type and do not cause seizure aggravation. That's the definition which we also put in a paper 2 years ago together with Frau Poczka. So valproic acid with an unknown mechanism of action is regarded as broad spectrum anti-seizure medicine. Others, such as lamotrigine, can cause seizure aggravation. And there are numerous reports where they aggravate myoclonic seizures in Lennox-Gastaut syndrome, where they're not working in SCN1A mutations, and they're not working in juvenile myoclonic epilepsy, which is especially important. And there's a clear need for anti-seizure medicine with broad spectrum efficacy. Perampanel has recently been licensed for focal and generalized tonic-clonic seizures in the context of IgE. And I mention that because it's probably the best IgE study so far, which has been done to look at the efficacy, because all of the patients have been analyzed by Czech-French study consortium whether the diagnosis is correct. So as we have now numerous case reports, small series in other generalized syndromes, we try to assess the efficacy. And we looked at a bibliographic databases of publications, clinical trials, conference acted up to August 2020. The protocol was published in Prospero. We identified 2,793 hits. We excluded 1,400. We assessed 300 full text articles and remained with a a few numbers of studies which were included into the synthesis. It's 109 studies. So 92 reports after full exclusion met the criteria to further go into that. 15 reports of one big randomized controlled trial, 8 reports of 4 non-randomized interventional studies, 37 reports of observational studies, 22 case reports, 10 systematic reviews and meta-analysis, with overall 360 patients with primary generalized tonic-clonic seizures, 251 with myoclonic seizures, 112 with absent seizures of various etiologies, 50 with tonic seizures, 32 with epileptic spasms. The most common syndrome was juvenile myoclonic epilepsy, but also progressive myoclonic epilepsy and absence epilepsy. And we know, for example, Baltic myoclonus worsens when you give phenytoin. So that's an important information to have other substances. So the result was clear because we have class 1 evidence for primary generalized tonic-clonic seizures, and we have class 3 and 4 evidence which support the effectiveness of perampanel in multiple seizure types, including myoclonic, absence, and tonic-clonic seizures. There were no patterns suggesting seizure worsening or aggravation. So these are the studies for generalized tonic-clonic seizures. In detail, I don't have to tell you the outcomes. The responder rate was around 70% in this patient group. These were the outcomes in myoclonic seizures. Here it's, of course, technically difficult to count, but the different study results show an improvement with responder rates up to 100% in some small series observational studies, and a dramatic reduction or abolition of myoclonic seizures in 9 of 13 cases, or 7 of 8 patients with progressive myoclonic epilepsy, and so forth. So there's a good efficacy in these reports, low class of evidence, and there is also efficacy in absent seizures. And there were some quite rare etiologies, for example, early juvenile Tay-Sachs disease, and so forth. So there is a lot of work out there, and the identified studies support the effectiveness of perampanel in multiple generalized seizure types. We found in this work no evidence to suspect an association between perampanel and seizure aggravation. But most of the studies were uncontrolled and non-randomized. So therefore, we are a little bit blinded for the true effect size. And all these studies, except the double-blind randomized controlled trials, they are prone to high risk of bias. It's a huge selection bias of the positive results. But nevertheless, let's go to another patient. A young man with seizures starting at 19 years during sleep, probably secondary generalized tonic-clonic or focal to bilateral tonic-clonic. Seizure type 2, a rising sensation in his stomach, losing awareness, focal seizures with impaired awareness. MRI was negative, and anti-seizure medicine, levetiracetam, that's how you start usually today, led to a depression. Valproic acid, oxcarbazepine, 1800 milligram was added, then brivaracetam was added, and the last medication had as a basis oxcarbazepine, 1800, lacosamide, brivaracetam. Perampanel was added up to 12 milligram, leading to dizziness. Topiramate was added, leading to memory deficits. Interictal EEG, sharp waves, left temporal, right temporal, and ictal EEG started left frontal, frontotemporal, rarely right parietal. Neuropsychological tests were done 2014 and 2020. These were the results. Green is within the normal range. Here at 2014, he had frontal executive dysfunction, and 6 years later, massive deficits in almost all cognitive parameters, especially in the memory domains. So what is the reason for this cognitive loss in this patient? We know there are multifactorial causes of cognitive deficits, personal variables, cognitive profile prior to onset of epilepsy, epilepsy-related variables, personal and family and psychiatric history, treatment-related variable, and psychosocial background, education. Most frequent complaints are in the cognitive and in the mood domain for all epilepsy patients. And the cognitive impairment have an enormous effect on patient performance and quality of life. At the onset of epilepsy, he had a girlfriend, and at the time of pre-surgical, as it happens in life, she left him. So she was sad for that reason. He had cognitive deficits at the beginning of the epilepsy. He had bilateral epilepsy, and on both temporal lobes, and he had pharmacoresistant epilepsy with a high seizure frequency, and he had treatment variables. Oxcarbazepine is not the best for cognition. So you have to consider this into your treatment schedule. Levetiracetam, topiramate, valproic acid are all contributing to neuropsychological deficits, but also lacosamide, and it could also be brivaracetam, and for sure oxcarbazepine, which impairs cognition. So important to recognize the iatrogenic cognitive effects, which are probably strongest in benzos, the old sodium channel blocker, carbamazepine, valproic acid, GABAergic drug, phenobarbital, and phenytoin. From the newer drug, it's topiramate and sonisamide, which stand out for having cognitive deficits, but also some reports on lamotrigine. High doses and polytherapy can be associated with cognitive adverse events. You have to use the lowest dose and rely on monotherapy wherever possible. And deficits associated with anti-seizure medicines are related to attention, dual processing, and memory. And for some medications, also naming and word finding, and this is what you have to look for. Patient is a 30-year-old woman with seizures starting at the age of 14, having a diagnosis of IgE with absences and bilateral tonic-clonic seizures. She had a wish for a child, and she was on valproic acid, so it was switched to levetiracetam. And at the next visit, she complained about fatigue and persistent sadness. So lamotrigine was initiated, and there was a hope that it works in this idiopathic generalized epilepsy patient. The other one is a 63-year-old woman with seizures beginning at the age of 62, focal seizures with loss of awareness and speech disturbance after an ischemic stroke in the year 2018. Treatment was started with levetiracetam, and at the next visit, the husband complained his wife changed, it's getting jealous and aggressive. She thinks that she is getting secret visits from another woman. Lamotrigine was initiated instead of levetiracetam, and the problem was not mentioned anymore by the husband, so it was solved. So there are psychiatric comorbidities in epilepsy patients, at least twice as common in patients than in the general population. The mental health screening should be part of a routine epilepsy care. What is the component of mental health screening? They should be done at epilepsy diagnosis and prior, following anti-seizure medicine initiation or changes, and at routine intervals, for example, once a year. It should include standardized evaluations of anti-seizure medicine side effects and measure the health-related burden of quality of life. Psychoeducation for those patients, parents, and caregivers, individually or in a group, are advisable when there are problems. And you should avoid certain drugs which are probably related to a higher frequency of psychiatric adverse effect. So GABAergic drugs as a group have, for example, a negative impact. So the downers, the classical GABAergic downers are phenobarbital and the benzodiazepines. But there are also newer drugs with a psychiatric adverse effect, GABAergic, vigabatrin, for example. With other mechanism of action are not downers, but they have a more irritable psychiatric profile, like levetiracetam or also perampanel, topiramate, sonisamide. But you have to know that there are also positive psychiatric properties where you can take advantage of. Mood stabilizing effects of oxcarbazepine, lamotrigine, valproic acid, but also probably of acetylcarbazepine, acetate, and carbamazepine. Anxiolytic effects of benzo, pregabalin, and gabapentin, and also antidepressant effect for lamotrigine. With the history of comorbid psychiatric disorders, the first choice should include treatment with positive psychotropic profile. Another patient, elderly person, 79 years, he had a late onset temporal lobe epilepsy starting at the age of 49 with arrest, with loss of awareness, aphasia, and focal to bilateral tonic-clonic seizures. The etiology was an FCD type 2. He had a resection 6 years ago, but seizures still remained. So he was dependent on anti-epileptic drug treatment. Valproic acid, topiramate, and levetiracetam was his choice. Esomeprazole, statins, citalopram, pramipexole, rivaroxaban were his cocktail for doing that. And look at that, valproic acid and pramipexole. I come to that later. Treatment in the elderly is complex. It's characterized by altered pharmacokinetic and pharmacodynamics, renal excretion, lower protein binding due to reduced albumin levels, impairment of hepatic and metabolic capacity. There's also a change in receptor density and sensitivity, which might influence pharmacodynamic properties of anti-seizure medicine. Polypharmacy in elderly is uncommon, and there's an increase in risk for drug-drug interactions, dose-dependent adverse effects in drug toxicity. Slow uptitration and low target doses are the way to proceed. There are randomized controlled trials showing clearly that controlled release carbamazepine is inferior as compared to levetiracetam and lamotrigine in a big randomized controlled trial published some years ago. So in reality, many patients in the elderly range are treated with first generation anti-seizure medicine, and you have the problem of the drug-drug interactions. Carbamazepine, oxcarbazepine, phenytoin may influence cardiac conduction, and there's a recent warning in the FDA that also lamotrigine may cause cardiac conduction problems, and this should be taken care of. Enzyme-inducing anti-seizure medicine, but also others such as valproic acid, levetiracetam or topiramate may cause metabolic derangements, which increase the propensity to have encephalopathic reactions, but also increase the vascular risk factors like dyslipidemia, rising inflammatory serum markers, homocystinemia, and atherosclerosis. So let's look at his. He has valproic acid, which is a P450 inhibitor. He has several comorbidities. He takes statins, NOACs, and antidepressants. And there's an increased risk factor for stroke, myocardial infarction, and cardiovascular disease with enzyme inducers. And he also takes pramipexole because he has a Parkinsonism, and it's not an idiopathic Parkinson's disease. It's a rare adverse effect after intake of valproic acid. Most cases show improvement with the withdrawal of the drug. So that's a complex situation. And complex situations need a complex care. And the complex care is only given in comprehensive epilepsy programs. And there are very few papers looking at the outcomes, healthcare outcomes in comprehensive care programs. And this is, to my opinion, the best study looking at more than 40,000 adult patients, 14,000 in non-specialist care, 10,000, close to 10,000 in neurologist care, and more than 2,000 in the Calgary Epilepsy Program of Care. And what they found is that the standardized mortality rate was 7.2% for the entire cohort, but only 2.8% for those seen in the Calgary Epilepsy Program. So the cumulative hazard of mortality clearly decreases when you have the patients in a proper epilepsy comprehensive program. Why? Because epilepsy treatment is complex, and it's not only the mechanism of action, it's the effectiveness of the drug, it's the causes, the proper diagnosis, and the treatment. Where is the future? If we look at what I showed you before, the rare and complex epilepsies, here we identify causes on a genetic level. For example, tuberous sclerosis complex or lesional focal epilepsy, which also have derangements in, for example, the GATOA1 and DEPDC5 complex, which can be attacked by some of the anti-seizure medicines which are coming. This is an overview slide, and some of them are repurposed old drugs where the mechanism of action was completely unrelated to its anti-seizure effect, but then later discovered that they are effective against seizures. Some of them are already on the market: fenfluramine, an amphetamine-like drug; cannabidiol; everolimus, the inhibitor of mammalian target of rapamycin; and cenobamate, which is a combined sodium channel blocking action with positive allosteric modulation of the GABA receptors. So to conclude, epilepsy diagnosis and treatment is challenging, and early referral to a specialist center is needed in any case of uncertainty. Outcome in specialized centers is better than standard of care. Correct diagnosis, appropriate medical therapy, identification of surgical candidates, and improvement of adherence. The knowledge of mechanism of action is helpful for the doctor in avoiding side effects and interactions, pharmacodynamic and pharmacokinetic. And genetic characterization of focal epilepsies will expand the therapeutic options and individualization of drug treatment on the horizon, and there definitely the mechanism of action of the drugs used is crucial to know when you know the exact pathophysiology of the underlying cause of epilepsy. Thank you very much for your attention, and I'm looking forward to questions and answers.